Here's our high-yield blueprint for today. 1. GIST risk classification. 2. Management strategies. 3. Key clinical pearls. 4. The classic exam trap. And finally, 5. A quick recall question to test yourselves.
Section 1. GIST risk classification. Okay, let's dive right into assessing recurrence risk, because honestly, that risk dictates literally everything else we do. Historically, we use the original NIH classification system, which scored the risk of recurrence using basically just two variables. You had tumor size and you had mitotic rate. This system breaks it down from very low all the way to high risk. So to put that into perspective, a tumor less than 2 centimeters with less than 5 mitoses per 50 high-power fields, that falls neatly into the very low category. But on the flip side, if a tumor is larger than 5 centimeters and has a mitotic rate greater than 5, or if it's just massive, like over 10 centimeters, regardless of the mitotic rate, it jumps straight to high risk. Also, any size tumor with a mitotic rate over 10 is automatically high risk. Now, it's a pretty elegant system, right? But clinically, we quickly realized it didn't quite capture the whole picture.
And that brings us to the modified NIH classification. This is the one you actually need to apply in practice. This system upgrades our whole diagnostic equation. It keeps tumor size and mitotic count, sure, but it adds two absolutely crucial new variables into the mix: tumor site and tumor rupture. Now you might be wondering, why did we need to add these? Well, let's look at the site first.
Now, what's really interesting here is how powerfully location influences the outcome. A key principle to remember is that gastric GISTs generally have a way better prognosis compared to small bowel GISTs. So what does that mean for you? It means if you're comparing two tumors that are the exact same size with the exact same mitotic rate, the one located in the small bowel inherently carries a worse prognosis. It's crazy, right? Location matters just as much as the physical characteristics of the tumor itself.
But out of all the prognostic factors, this right here is the real game changer: tumor rupture. If a GIST ruptures, whether that happens spontaneously or during surgical manipulation, it is a major adverse prognostic factor. A ruptured GIST is automatically considered extremely high risk for recurrence. It completely shifts the entire clinical pathway.
Moving on to Section 2, GIST management strategies.
So, if your patient presents with a localized resectable GIST, the standard treatment is actually pretty straightforward: complete surgical resection with negative margins. But, and this is a huge but, the absolute necessity for the surgeon is to ensure strict avoidance of tumor rupture. There are absolutely no heavy hands allowed here. As we just learned, if you accidentally rupture that capsule during resection, you have instantly upgraded their recurrence risk to extremely high. So gentle tissue handling is absolutely paramount.
And here is a massive surgical distinction you got to keep in mind. When we're performing that resection, routine extensive lymphadenectomy is generally unnecessary. I know, right? A surgeon who doesn't want to cut out every lymph node in sight? Sounds like a trick question. But think about other GI malignancies for a second. You're usually taking all the draining lymph node basins. Not here. Because GISTs rarely spread to the lymph nodes, going after them doesn't improve survival. It really just adds unnecessary morbidity to the procedure.
Okay, so beyond surgery, what about medical management? Well, this is where targeted systemic therapy steps in. For high-risk GISTs that have been completely resected, adjuvant therapy with a tyrosine kinase inhibitor, specifically imatinib, might be indicated. That is, provided the tumor actually has an imatinib-sensitive mutation. Now, if a patient presents with an unresectable or metastatic GIST, imatinib becomes our first-line systemic treatment. And if the disease progresses or proves resistant, we simply escalate to other TKIs.
All right, Section 3, Key Clinical Pearls.
I want you to burn this core triad of GIST assessment into your memory right now: size, mitotic rate, and site. And this brilliantly illustrates the three major prognostic factors you have to know. If you can instantly recall those three, alongside the catastrophic risk of tumor rupture we talked about earlier, you've pretty much mastered the clinical foundations of assessing a GIST.
Section 4, the classic exam trap.
So the crucial point here is that a GIST is not managed like an adenocarcinoma. When an examiner gives you a question about a mass in the stomach, your reflex might be to jump at the answer choice that includes a radical resection with wide lymph node dissection. Why? Because that's exactly what you do for gastric adenocarcinoma. Do not take that bait. For a GIST, the key goal is complete resection with negative margins, and absolutely zero wide lymph node dissection is required.
There's also a secondary trap to watch out for. The vignette might describe a really small tumor, let's say a 2.5 centimeter mass. They do this to give you a false sense of security,
hoping you'll quickly categorize it as low risk based on physical size alone. But always, always check the pathology report. A small gist can still be high risk if the mitotic rate is high. Never assess size in a vacuum.
Let's move to Section 5, our quick recall question, and see how this all builds together.
All right, here is your hypothetical patient. A gastric gist is found. It's 4 centimeters in size. The pathology shows 3 mitoses per 50 high-power fields. And importantly, there was no rupture during surgery. So, based on everything we just discussed, what is the risk category for this tumor? I'm going to give you a second to actively synthesize those variables.
And the answer is low risk, specifically under the original NIH criteria. Let's break it down. It's a gastric tumor, which is favorable. It's under 5 centimeters and has fewer than 5 mitoses per 50 high-power fields. Plus, without a rupture, this patient falls firmly into the low-risk bracket. Synthesizing these variables rapidly isn't just the key to acing your surgical exams, it's literally the key to making precise, life-saving decisions on the floor. But think about this. What happens to this patient's entire treatment trajectory if the pathologist miscounts that mitotic rate by just 2 cells? The margin of error is razor thin. See you in the next explainer.